Hello everyone, it's Kane Guthrie here, and I'm going to talk to you today about uncommon and refractory shock cases. So thinking a bit outside the box, when we're dealing with a shocked patient and patients with refractory shock, what do we actually need to do for these patients? And there's lots of algorithms out there for what to do when we're dealing with a shocked patient, but sometimes we get to the end of those algorithms. And that's what this talk is all about, is what to do when you get to the end of that algorithm to actually manage and resuscitate these patients. So it's what some of the resuscitationists talk about, is becoming an end of algorithm experts. Some of the things I'm going to highlight is some new concepts in the resuscitation of shock. We're going to look at some uncommon cases, and I'm going to give you an approach to the actual refractory shocked patient. So what is shock? And there's two ways that we can look at shock, and quite often we think of the shocked patient as the hypertension patient, but we know that hypertension doesn't always mean that they've got shocked, so we can think of it as a low blood pressure. But the other thing we need to think about when we're dealing with the shocked is actually looking at their mean arterial pressure. We know that in a normal hemodynamic state, we like to have a mean arterial pressure above 65. And that generally results in good organ perfusion. There's some conditions that we like to have a higher mean arterial pressure for organ perfusion, things like spinal cord injury, traumatic brain injury. But generally, when we're looking at the sick patients, or patients in general, we like to see that their mean arterial pressure is sitting above 65. And I think shock in a nutshell is about where there's failure to meet the end organ, the body's metabolic needs, and that's what results in end organ dysfunction, so where you get hyperperfusion. And remember, you can have a normal blood pressure and still be shocked as well, and we're going to talk a little bit more about that as we go through the talk. So when we think about the shocked patient and the shocked patient at the end of the bed, the most common types of shock that we see in the emergency department are septic shock, which occurs about 60% of the time. Hypervolemic shock is common, so dehydration, massive trauma where there's blood loss. Less common, we start moving into the obstructive type shocks, so things like pulmonary embolus, cardiac tamponade, tension pneumothorax. A new kind of cardiac type of shock that we're looking at is left ventricular outflow tract obstruction, which is the LVOTO. We see cardiogenic shock, and that can be caused by a myriad of causes. There's anaphylactic shock, which can present subtly with no urticaria and no rash and just hypertension, or it can present with full urticaria, angioedema shock. There's some endocrine causes as well, which we're going to look at some of those cases. And then the disability is where you get some of your neurogenic type shocks or your dyshemoglobinemias, and we'll touch on them a little bit in the refractory shock type. Just highlighting them, but generally if you've got a shocked patient in front of you, 60% of the time it's going to be sepsis the cause. And we know with sepsis shock, at least a good 40% will be a urinary source, the other 40% will be a chest source, and then your other 20% is your skin, brain type, meningococcal, encephalitis type pictures as well. So that's what can actually help guide us through us. So the rest of this talk, we're going to be looking at about those 10 to 20% of cases that aren't the septic shocks, but these patients still present in shock states. Some presentation pearls when we're looking for these shock patients, and that quite often when we look at shock patients, they don't always present, and it's all where you see them over that disease trajectory and presentations. Quite often they'll present with these non-specific symptoms, so things like fatigue, malaise, weakness, dizziness, altered mental status may just present as a syncopal type event. So we need to think about these non-specific symptoms, that could they be harboring something else that's more sinister, and not downplay these symptoms as being kind of non-specific. They could actually be quite specific, and we need to investigate and look a bit further when we're dealing with these patients, especially in the elderly, those that are immunocompromised, Aboriginal and Torres Strait Islander people, and that they will often present with these non-specific symptoms, and it can be a red flag that something more sinister is going on. Another presentation pearl that I think that we tend to harbour on and focus on the hypertension, and that we consider that this is synonymous with shock, but you can have a normal blood pressure and still be quite shocked. Sometimes we notice that patients don't become quite hypertensive till later in the disease course when it's quite overwhelming, and this is often referred to as cryptic shock. And remember that blood pressure doesn't equal perfusion. And we're going to look at this concept a bit more. So having a good blood pressure doesn't mean you're perfusing your organs and your tissues as well as you should be. Okay, so sometimes we can anchor on and get falsely reassured by a reasonable blood pressure or even a saggy blood pressure that this patient isn't as sick as we think they are, and they actually are quite sick. So you just need to be mindful of that. And so this is a study, it was done a few years ago, but back in 2009, but it's still quite relevant to emergency care and emergency departments. And this looked at the significance of non-sustained hypertension in emergency departments with sepsis. So these were patients that had one episode of hypertension during their emergency department visit and their overall end outcome. And what this showed, it was a secondary analysis study, and it was a prospective study, so they actively recruited patients into this trial. It had a fairly decent sample size of 700 patients. And of those 700 patients that presented with sepsis, 21% had an episode of non-sustained hypertension, so one episode of hypertension in sepsis. And what that showed, that there was a threefold increase in mortality. So these patients were 3 times more likely to die just from having a single episode of hypertension. So if you get a single blood pressure coming up that shows that the patient's had an episode of hypertension, we need to take that seriously, adequately review that patient and resuscitate as appropriately. Don't dismiss it, okay? And we know that this is the same in things like myocardial infarction, trauma, cardiogenic shock. One episode of hypertension worsens their mortality. Okay, so that's why we need to be cycling our blood pressures regularly in those patients that we're aware of. We need to be interpreting the data. We need to be looking at their mean arterial pressures and stuff, and generally advocating for early outline and invasive monitoring in these patients that are potentially critically unwell. Another thing that we can use at the end of the bed that we don't look at very often is what we call the shock index. And so the shock index is where you divide your heart rate, divide your systolic blood pressure. And that gives you a score. So a normal shock index is generally less than 0.7, and a shock index of over 1 is the most specific predictor that this patient's got organ hyperperfusion. So they'll have a higher lactate, and they also have a worsened 28-day mortality. We know that a shock index above 0.8 in these patients, that we need to actually lower our induction drugs during intubation because they're at risk of post-induction hypertension and cardiac arrest occurring. And so it's a simple thing. And the way I tend to look at it at the end of the bed, that if the patient's heart rate is greater than the systolic blood pressure, they've got a shock index at least 0.08 to 0.9. Okay, and we need to then look at these patients, and we need to resuscitate these patients more aggressively to actually improve that shock index, okay, because they will crash if we do try an induction, and they won't have a lot of tolerance for any further insults. So these are the patients we need to fluid resuscitate, and we need to get early vasopressors on board as well to maintain that systemic perfusion that they're relying on. Another thing that we can look at the end of the bed is the patient's heart rate, okay? And so heart rate is king in these patients. We know that tachycardia is generally expected in the shocked patient, but bradycardia should worry us. And the thing that we can look at is the pulse pressure as well. So this is the systolic minus the diastolic, and we tend to see these pulse pressure waveforms can look at that when we're putting in arterial line because it gives us a real-time end of the bed blood pressure. It also provides us with that mean arterial pressure. So when we're interpreting these pulse pressures, if someone's got a wide pulse pressure, so that's greater than 40, they're often in what we call a vasodilatory type shock state. And we see these in patients with septic shock, neurogenic shock, anaphylaxis, liver failure and cirrhosis, and adrenal and thyroid issues as well. So they've got a nice wide pulse pressure, and that's generally from that vasodilatory type shock. When you notice that someone's got a narrow pulse pressure, they generally have a decreased cardiac output and stroke volume because of that. And you can see there on that dichotic notch in that it's quite narrow and quite short. And we see that in hypervolemic shock patients. We see that in cardiogenic shock patients, cardiac tamponade, tension pneumothorax, and aortic stenosis as well. And as I've said before, having a normal blood pressure doesn't mean that these patients are adequately perfusing their tissues. So we need to make sure that these patients are adequately perfusing. So we need to touch them as well. And so we need to look to see what their capillary refill time is, because that's consistent with organ perfusion as well. If they've got a slow and sluggish capillary refill time, whether it's central or peripherally, then you will often see skin mottling in that, and we know that they're not perfusing those distal tissues, and they're most probably not perfusing their other organs as well, things like kidneys, liver, heart, lung, brain. Urine output can be an early indicator and tell us that they're not perfusing their kidneys as well, and lactate as well. Lactate tells us if they've got anaerobic metabolism. So a lactate should be generally less than 2. Anything above 2 is a measure of anaerobic metabolism. Lactate greater than 4, we should be worried. And anything higher than 4, we need to consider what is the cause of that lactate. Remember, there are some drugs that will raise your lactate, so beta agonists, so salbutamol, adrenaline, vasopressors as well, if they've been started on, will raise your lactate. But those patients that haven't had those drugs and they've got a raised lactate, we need to find out why they're not perfusing their organs, which organs they're not perfusing, and tailor our treatment to those specific needs. This is a study that was done in Brazil in 5 big ICUs over there, and it looked at measuring capillary refill time, so peripheral perfusion, versus their serum lactate in septic shock. And what the study showed, basically they compared doing regular capillary refill times and regular blood lactate, and noting that a capillary refill time above 3 was a sign of organ hyperperfusion. And that was actually comparable, and there was no significant difference between the groups. So doing capillary refill times and looking for sluggish and slow capillary refill times is just as good a measure in this study as doing lactates. We do prefer lactates because it gives us numerical data, and we can actually target our resuscitation to see if we're improving or not. But also we can do capillary refill time, so we can give a fluid bolus, we can start them on noradrenaline, and we can see if they're actually increasing their perfusion or not. Moving on now to talk a little bit about refractory shock. So this is when you've got a patient that you know that they're shocked. You've started your initial treatment, you followed all those algorithms, but the patient's getting progressively worse. And we see this as worsening cardiovascular failure. They generally will have a poor response to vasopressors. And we can see in this picture, they've got poor tissue perfusion. So this is a lady with multi-organ failure from a urinary source. And you can see there, those legs are cold, they're mottled, and capillary refill time will be about 6 or 7. They often are severely and refractory hypertension, and they start to develop progressive organ failure very quickly. So refractory shock is generally when our trusted treatment paradigms fail, and where our aggressive and conventional resuscitation fails. So we notice that they get an inadequate hemodynamic response to vasopressors, fluid resuscitation, and this leads to this downward spiral of refractory shock. It occurs in about 7% of patients, and it has a mortality rate of about 50 to 80%. So our goal in resuscitation is to prevent patients from getting to this. So this is where we need early recognitions of critically unwell patients and getting them resuscitated and stabilized as soon as possible to prevent them going on this spiral into refractory shock. So this is where your early recognition of shock and identifying and treating the underlying cause, adequately fluid resuscitation and making sure that they're a fluid responser, starting them generally on noradrenaline. Noradrenaline is generally your safest type of vasopressor and the one with the most evidence in most shock cases these days, and that's from septic shock to post-cardiac arrest to neurogenic shock, all those types of things. Noradrenaline is generally your first choice. You want to, when you're dealing with severe shock, this is when it's time to identify and treat contributing pathophysiology. So if they're ongoing hypervolemia, making sure that they're getting adequate fluid resuscitation. Remember though, if they're losing blood, we want to give them blood. We don't want to dilute them with saline or CSL. If they're getting progressively worse acidosis or an acute kidney injury, this is when we need to advocate for them to go up to intensive care. And that's when they can do things like continual renal replacement therapy, so dialysis, or they can sometimes use sodium bicarbonate infusion to alkali that acidosis. Treat hypocalcemia early, and we're going to talk about that in the case coming up, but calcium supplementation. Calcium is generally, we need to optimize it, and calcium works very much as a chronotrope and helps the heart, and we see it's quite often depleted in shock states, and we need to early and aggressively advocate for calcium optimization because that can help with their overall perfusion and heart contractility. If you're failing with noradrenaline in these patients and you're maxing out on noradrenaline, that's when it's time to add in a second vasopressor agent. And you can look at them there, but there's things like vasopressin or adrenaline, dobutamine as well. Other things to consider in the severe shock case is using low-dose hydrocortisone. And so generally if patients are on steroids normally, we'll give them a bolus dose or a stress dose of hydrocortisone. Other things they may consider up in ICU is ascorbic acid or thiamine infusions. There's not great evidence that these will do a lot, but it's a last-ditch effort at throwing it to try and decrease some of that mortality. If you've got refractory shock, so you're not winning with any of that, you need to try and make sure you've identified all the treatable pathology and optimize everything that. And then there's some rescue therapies, and these are generally done up in ICU, so they may use methylene blue for dyshemoglobinemias and stuff, and to actually help with nitric oxide production. And hydroxycobalamin is another one, which is high dose vitamin B12 and that. Not amazing evidence for it, but they're going to throw the kitchen sink at these patients to try and decrease their mortality. And this is what it looks like from a pathophysiology perspective. So this is the death spiral of shock. So we know we've got a shocked patient, and you can see they're moving over to the right. You get decreased tissue hyperperfusion. That leads to myocardial dysfunction, so poor contractility, which leads to worsening tissue perfusion. We also know there's another step in that which releases vasodilators, so things like nitric oxide and systemic inflammation, and all this becomes overwhelming, and this is when we get vasoplegic. So this is where the heart doesn't contract very well, fluids in the third space, starts extravasating, and nothing's working well to actually maintain the systemic perfusion. So you need to fill up and keep the fluid in the intravascular space, but you also need to improve that contractility to overcome that vasoplegic state that's occurring. We're now going to go through some case studies. So I want you to meet Amanda. She presents to ED. She reports that she's had a 3-day meth binge, and she presents with this altered mental state from what you can gather. She's got vomiting and diarrhea, and you notice that her BSL is 2.4. You get her onto the cardiac monitor. We can see that her heart rate's 97. She's profoundly hypertensive, so she's got a blood pressure of 58/40 with a mean arterial pressure of 47. She's a little bit tachypneic with a respiratory rate of 23. And she's hypoxic with an SpO2 of 89. So Amanda's got these quite worrying vital signs, and she needs early and aggressive resuscitation to restore her hemodynamics. You manage to try and get some history from her. She does have a history of a kidney problem, is all she can tell you. She's an intravenous drug user, and methamphetamine seems to be her choice of drug at the moment. She's got a background of borderline personality disorder. She's meant to be on some medication, but she doesn't take it, and she also tells you that she's very allergic to Panadol. So quite a sketchy and complex history there that you need to work through. You managed to figure out, though, that Amanda, from her records, has a history of Addisonian's disease. And this could be an Addisonian crisis that Amanda is presenting with. So Addisonian crisis is an endocrine emergency. And this is where the patient has acute deficiency of cortisol, or they've got a known adrenal insufficiency. It has a 6% mortality in crisis, and we often miss adrenal disorders and Addisonian crisis because they quite often present shocked with these vague symptoms, and it's not something we test for. So unless we've got a history of it, it's not something that we'll look for, but it's something we should keep in mind, especially in the younger type population that presents quite severely shocked like Amanda did. So your pathophysiology of Addison's disease is this is where they've got severe cortisone and aldosterone deficiency. So we know that when there's stress on the body and the hypothalamus, this then affects the pituitary gland that decreases actual ACTH, which then doesn't get produced in the adrenal glands, and they start getting deficiency in aldosterone and cortisone, and this can then cause some electrolyte abnormalities. So they may have not be able to reabsorb sodium, they'll have increased potassium excretion, and they'll have trouble with water reabsorption. So they'll actually get quite severely dehydrated and with poor electrolyte functions from that. From the cortisol side of things, then they get this immune system dysfunction and metabolism. So they present with this distributive shock type picture as well. So if you think of Addison's, we want to send some bloods off. So your ACTH level, your cortisol, aldosterone and renin levels, you send them off. They'll take quite a while to actually come back, those tests. It's not a quick turnaround test from PathWest. So we're going to then treat it and not wait for the bloods to come back, because as you can see, she's severely shocked as it is. So we need to crack on and treat it. Your clinical presentation that you'll look for these patients is that they'll present with severe hypertension that's actually refractory to fluids and vasopressor type agents. So you'll give them vasopressors and they just won't get better. They often present with GI symptoms, so nausea, vomiting and diarrhea. They'll be clinically very dry and dehydrated. And because of that dehydration and electrolyte abnormalities, they'll present with weakness, lethargy, altered GCS. Some may report some pain in their flank, back and chest as well. Your complications for someone that presents in an Addisonian crisis is that they may develop some arrhythmias related to electrolyte abnormalities. They can present in cardiac arrest, once again from a severe electrolyte abnormalities. They'll have refractory hypertension that can lead to multi-organ failure. And they may also present with hypoglycemia that results in coma if we don't aggressively treat it and rectify it and optimize all those electrolytes. So potassium, sodium, calcium, glucose all need aggressive optimization. So your treatment for someone presenting with Addisonian crisis, if you suspect it, you're best to just treat it and not wait for the bloods, because the bloods will take too long to come back. You're going to treat them with hydrocortisone is the preferred drug, because that has a glucocorticoid and mineralocorticoid effect. Your dose is 100 milligrams stat and then 100 milligrams QID. If you haven't got hydrocortisone for some reason, you can use dexamethasone as an alternative, but hydrocortisone is generally preferred. You're going to give them lots of glucose if they're hypoglycemic. You're going to fluid resuscitate these patients because they're severely dehydrated and they've got a distributive shock. You want to optimize their electrolytes, and they're quite often going to need some vasopressor support until that hydrocortisone starts to work and starts rectifying that adrenal insufficiency in crisis. So moving on now from Addisonian crisis, we're going to meet Ethel. So Ethel is an 85-year-old female. She's your typical type Charlie's patient. She presents generally unwell. She's not been eating or drinking, and she reports that she's had 1 vomit. Ethel comes into your resus bay. You get her on the monitor, and you see that Ethel, she's a bit bradycardic with a heart rate of 44. She's got a blood pressure of 85/60, so quite low for someone of Ethel's age and some of Ethel's history, which we'll look at in a second. She's got a temp of 35.7, and saturations are okay at 94% on room air. When we look at Ethel's past medical history, she's got a history of AF, hypertension, which is on metoprolol and ramipril for. She's got hypercholesterolemia, which she's managing with diet. She's got some macular degeneration, and she's got a history of a TIA in the past. You get a 12-lead ECG for Ethel because you know she's quite bradycardic. It's not very specific. It's a bit of sinus bradycardia there. Maybe a first-degree heart block, but there's nothing too concerning there from the ECG for Ethel. But then we get Ethel's blood gas vac, and we can see that Ethel's acidotic. She's got a pH of 7.245. PCO2 is a little bit on the lower side at 21. PO2 is at 44. Bicarb is 9, so that's quite low. Her sodium's touch on the lower side at 133. Her potassium's very high at 7.5, which is surprising. And with her ECG, we do look back at it now and notice there could be a little bit of peak T waves in that. Chloride's fine, calcium's okay there. A little bit hypoglycemic, but lactate is 8.9, and she's got a renal impairment, which is new for Ethel. So creatinine of 499 with anaerobic metabolism going on there and a metabolic acidosis. So pH is 7.2 and she's got a lactate of 8.9 with hyperkalemia. So we're very worried about Ethel based on this blood gas. And so she needs to have a senior doctor and senior nurse at the bedside to aggressively resuscitate and optimize Ethel because of this blood gas. And Ethel has this condition called Brash syndrome. And so Brash stands for bradycardia. We saw that her heart rate was 44. She's got renal failure, so her creatinine was 499. She's got a first degree heart block on her ECG, so she's got AV blockade. She's shocked, she's hypertensive, and she's also got hyperkalemia. And so we know with Brash syndrome that these patients present with renal failure that results in hyperkalemia, and this is generally because she's on an ACE inhibitor or an angiotensin blocker. Ethel's also on a beta blocker with metoprolol, which will worsen the actual renal failure and the bradycardia, and this leads to poor renal perfusion, and that's where it builds up. So she's got a worsening creatinine, worsening hyperkalemia, and worsening acidosis that we need to treat. So the Brash syndrome, the things to look for in these patients is that they're generally elderly, they have very vulnerable kidneys, they're prone to volume depleting illness. Ethel's presented with a bit of vomiting and stuff, and they're taking AV blocking drugs, so your angiotensin receptor blockers, your beta blockers, calcium channel blockers as well can cause Brash syndrome. So with Brash syndrome, it's generally a synergistic process combination, so of hyperkalemia, which develops from the poor renal perfusion, and the AV nodal blocking drugs because they're not being renally excreted. So that's where they present with hypertension and bradycardia, which hyperkalemia contributes to it as well. So quite often it's the medications that are causing it, but it's also they can get a gastro-type illness as well and develop some form of hypervolemia that exacerbates the Brash syndrome. So often these patients can present from being asymptomatic, Ethel wasn't that unwell, to actually being in full multi-organ failure and shock. Hypervolemia is common, and that's from the GI causes, and the hypervolemia worsens the poor renal perfusion, and that gives them the acute kidney injury, which prevents the AV blocking drugs and potassiums being excreted. The AV blocking drugs then keep accumulating, that results in the bradycardia shock, and they get worsening kidney failure that needs treating. So your treatment for someone that presents with Brash syndrome, generally they're going to be clinically dry, so we need to adequately fluid resuscitate them. They've got hyperkalemia, which they will have. We need to treat with that. So IV calcium to stabilize that myocardium. Then you need to give insulin dextrose to drive the potassium from the extracellular space into the intracellular space. You can use beta agonists, so salbutamol nebs, to actually lower it. We tend to avoid diuresis in these patients because they're generally clinically dry, hypervolemic, and you will make them worse, the Brash syndrome worse, so avoid giving them stuff like furosemide. They may need to go up for dialysis to intensive care for that. The bradycardia management, it should improve a little bit with the IV calcium, and occasionally they may need an adrenaline infusion to support them until their kidneys start functioning and they can start excreting the medications and the potassium from the body. So that was Brash syndrome in a nutshell. Moving on now, we're going to look at Peter. So Peter's a 67-year-old male. He's just got home from private hospital and he's day 4 post having a total knee replacement. He collapses in front of his wife at home. She starts bystander CPR. She calls the ambulance and the ambulance get there. He's in out of hospital cardiac arrest. They got the Lucas on. They were able to shock him and give him adrenaline, and they'll got return of spontaneous circulation. And Peter presents to you guys post-arrest, but he's profoundly shocked. So he's got a BP of 71 on 53. He's got a heart rate of 109. He's got a SATs of 96% on an FO2 of 100 via an ET2, and he's afebrile. We get Peter to the scanner because we think that this may be a cause of a pulmonary embolus, given that he's day 4 post a total knee reconstruction, and that confirms the diagnosis that Peter's got quite a massive pulmonary embolus load there in his pulmonary vessel leading to his heart. Okay, and this is most of the cause of his cardiac arrest. So he's got this massive amount of clot sitting there in his pulmonary artery. So why do patients die from pulmonary embolus? And we quite often think that it's due to hypoxia, but patients die in pulmonary embolus, and big pulmonary embolus is from cardiovascular collapse. So we know when you develop quite a moderate sized pulmonary embolus that you get increasing pulmonary vascular resistance, and this causes the right ventricle to dilate. And from that right ventricle dilate, you get right ventricular hyperperfusion and ischemia. We tend to then give more fluids, but we know in right ventricular failure, the fluids don't work because it's an afterload problem. Okay, and so giving more fluids can actually worsen the hypertension. This can also lead to increased right ventricular wall stress that actually makes the right ventricle quite ineffective and with poor contractility. Your septum will actually bow from there, your right ventricular septum into your left ventricular, and this decreases your left ventricular filling. And all this results in further hypertension and shock, and this is where if we don't intervene or do a treatment, they do go into cardiac arrest from the cardiovascular collapse that's causing it. It's not actually from the lungs and the hypertension, but it's actually the direct effect that's occurring with the right ventricle. So how do we treat someone that's got a massive pulmonary embolus like Peter has here? So we can use thrombolytics, okay? But there are some contraindications, so we need to go through a checklist there, but the main one being alteplase. If they've got no contraindication, you can give them quite a large dose of alteplase, up to 100 milligrams. If they've got some relative contraindications, so Peter's had a recent total knee replacement, so he's at risk of bleeding from that, we may go for 50 milligrams of alteplase. We need to maintain their perfusion. Okay, and giving them more fluids is going to worsen that right ventricular function. So we need to start these patients early on noradrenaline to actually maintain that adequate mean arterial pressure. And if the noradrenaline starts failing, then we need to look at things like inhaled nitric oxide, which is a pulmonary vasodilator. We need to optimize their oxygenation as well, because they will have a VQ mismatch from that and present with quite severe hypoxemia. So we want to have a low threshold to start high flow nasal cannulas, and we want to maintain their SATs above 95%. And we also want to reduce their work of breathing. We need to often intubate these patients and help with their lung perfusion that way as well, so intubating them as well. But remember, these patients are critically unstable and will struggle on induction with induction drugs and can result in cardiac arrest there. So it's best, if you're going to intubate them, we need to do something to try and lower that clot burden that's causing strain on the right ventricle first. So generally, if you can thrombolyze them first before that. Other surgical and interventional type things they can do. So cardiothoracics can take these patients to theatre and do an embolectomy, or interventional radiology can sometimes go in and go interventionally to actually suck out some of that clot burden that way as well. And the overwhelming thing that occurs here is right ventricular failure, which I've already described, but we know that they've got this abnormal preload that causes reduced contractility that actually increases your afterload into your left ventricle. And this is what causes that cardiovascular collapse and spiral of death in a patient with pulmonary embolus. So your massive PE management that I've talked about is thrombolysis, so alteplase, embolectomy. We want to maintain hemodynamic perfusion. And with the right ventricular failure, these patients will get severe pulmonary hypertension. And so the way to treat that pulmonary hypertension is that we need to use pulmonary vasodilators. And so something that they tend to use up in ICU is inhaled nitric oxide. We tend not to have that down in the emergency department, but there's some new literature and concept out there that looks at this, and that is nebulized GTN. So nebulized GTN is a pulmonary vasodilator. It's a short-term stopgap measure for the crashing patient, and we're going to use this instead of inhaled nitric oxide. So other indications that we could use nebulized GTN as a pulmonary vasodilator is in an ARDS patient with refractory hypoxemia, and this is what we saw with the Delta wave of COVID, that these patients were presenting with refractory hypoxemia from their ARDS. In patient that presents with decompensated chronic pulmonary hypertension, the crashing PE patient, or in an inferior MI, so a shocked right ventricular MI as well is another indication where we could try nebulized GTN. So your dose, you're going to use your IV GTN, so you draw up 5 milligrams out of the vial, and you're going to nebulize it over 15 minutes, and you can last about 30 minutes, and you can repeat it as much as possible. Another way is you can do 200 to 400 micrograms per mil and just run it as a continuous nebulizer. But generally 5 milligrams over 15 minutes and see the clinical effect, and then titrate it to as need. So you just draw up the nitroglycerin from the IV, dilute it with a couple of mils of saline, and nebulize it that way. So we give Peter some alteplase for his PE. We also notice that, and he has a nebulized GTN as well, and he actually improves post some noradrenaline and the GTN neb. But then we do an E-fast because we notice that he's getting some abdominal distension, and we're worried that he might be bleeding inside his abdomen. So we take Peter to the CT, and that confirms our suspicions. And so this is a CT scan of his abdomen, and you can see in that circle there, that white bit in the middle is what we call blush. And so this is a sign that Peter has actually got a liver rupture, and that is the contrast seeking out into the retroperitoneal space that shows that he's got free fluid and potentially bleeding into his abdomen from a ruptured liver. So Peter's got a liver laceration. We're worried that it was from the Lucas that induced it. And so the Lucas are mechanical CPR devices, and they're just as good as humans at doing CPR, but they can result in some mechanical complications, and liver laceration is one of them. So Peter's now developing hypovolemic shock. So remember, he's been thrombolyzed as well. So he's bleeding out into his abdomen. So we start the massive transfusion pack. So we're giving him a 1-to-1 of platelets, FFP to packed red blood cells. We give him tranexamic acid, and his hemodynamics start to improve from that. So Peter gets about 6 units of red cells, FFP and platelets and his hemodynamics do start to improve a little bit. But then we start to notice that he's circling the drain again, and his hemodynamics are starting to worsen, and we're starting to get a bit worried and wondering if he's got further bleeding and stuff. You look at the monitor, and that we see that Peter's now further tachycardic with profound hypertension again. Saturating okay, respiratory rate's okay, but he's got suddenly progressive tachycardia and hypertension. We do an echo on Peter's heart, and this is what it shows. So we notice that there's very poor contractility there of his heart. It's not contracting very well. Remember, he is post-cardiac arrest with a massive PE, so we're not expecting a great echo, but we're expecting a bit better echo than what we're seeing there. So Peter's got what we call cardioplegia on his echo. So we do reassess his airway, breathing, circulation, disability and exposure, and we do a blood gas. We notice that he's still quite acidotic with a pH of 7.18. His PCO2 is okay at 52. His HB is 98 and his lactate's 4.5. But his calcium comes back at 0.3, which is severely low and profoundly hypercalcemic. So we know that hypercalcemia is seen in severe sepsis, but it's also a big problem in patients that are bleeding that we're giving blood to. So to maintain the blood outside the human body, they actually fill the blood up with citrate. And citrate is a form of chelation that when you give patients lots of blood, that'll actually drop their calcium because the citrate absorbs all the calcium in their body. So when you're giving patients bloods, even if it's 1 to 2 units, we should be optimizing their calcium as well, because calcium is chronotrophic and it will actually help with the contractility of the heart. So it's something that was missed in this case. So we need to actually fill Peter up with some calcium, and that'll actually improve his contractility of the heart. So treating the hypercalcemia, generally we can use calcium gluconate. So calcium gluconate is 2.2 mils of calcium, where calcium chloride is actually 6.6 mils of calcium, and that. So calcium chloride is 3 times more stronger than gluconate. If he's got a central line in, it's better to use chloride because it is more potent. If you're giving it peripherally, you can use chloride, but you can also use gluconate. You just need to give a bit more. And so you should see real-time end of the bed improvement when you actually increase the calcium level. So this increases mean arterial pressure, and when we re-echoed him, we noticed that he had a much more improved cardiac output from that. So always think about, if you're giving patients blood, patients are bleeding, optimize their calcium, okay? Because the heart is so dependent on them. And when you're filling them up with blood and that, they're getting that citrate toxicity from it as well. All right, so we saw Peter was a very complicated case. We're now going to move on to Bill. So Bill's a 68-year-old male. He presents with a history of hypertension, non-STEMI, and atrial fibrillation. Bill gets a recent diagnosis of prostate cancer, and life's not going too well for Bill. So he decides to take 50 times 240 milligram of verapamil slow release. So verapamil is the calcium channel blocker, and that's quite a lethal and toxic dose of calcium channel blocker in an overdose. So you get Bill into your emergency department, and you notice that on arrival he's profoundly shocked. So he's got a blood pressure of 67/30 with a MAP of 38. His GCS is 15. He's alert and talking to you. He's got a temp of 36.1 and a BSL of 14.3, and he's bradycardic already at 49. So Bill's got quite a severe calcium channel blocker, and we know that overdose, and we know that ingestion of even 2 to 3 times the normal dose of calcium channel blockers can result in toxicity. Ingestion of more than 10 tablets of calcium channel blockers is potentially life-threatening, with verapamil and diazepam are the most toxic in calcium channel blockers. Remember that patients that are on calcium channel blockers are generally advanced age with comorbidities that actually adds to the toxicity, and the difficulties in trying to resuscitate these patients aggressively as well from those underlying comorbidities. We know that the calcium channel blockers comes in standard presentation, so quick release and then slow release. So with the standard preparations, symptoms can start within 1 to 2 hours, like has occurred in Bill's, but in the slow release preparations, symptoms can take 12 to 16 hours to develop. So we need to make sure what they've taken, because sometimes if it's a slow release presentation and we watch them for 2 to 4 hours and we think, no, they're going to be fine, and we discharge them in that, but it's actually a slow release presentation, they will actually go into a spiral of cardiogenic shock after that 12 to 16 hours. Your clinical features that you'll see early on, so generally they'll present with bradycardia, first degree heart block, hypertension. This will generally move into progressive to refractory shock and hypertension, where myocardial infarctions and strokes can occur from that as well. So yes, clinical features as well from a CNS point of view, seizures and coma are rare, but if coma does present with calcium channel blocker overdose, they've generally taken another agent as well, or alcohol on top of that. From a calcium channel blocker point of view, they generally will present with hypoglycemia and lactic acidosis as well from organ hyperperfusion as a direct result of the calcium channel blocker toxicity. So this is a time critical presentation and we need to get help early and aggressively, and this is when we're going to speak to our toxicologists. You're going to want to do a screening 12-lead ECG on these patients, a BSL and a paracetamol level. And if your patient is hypertension that was refractory to fluid resuscitation, this is a sign that they've got severe toxicity and we need to be very aggressive in our resuscitation moving forward. So you want to be prepared early for that these patients will get refractory hypertension. Cardiac arrhythmias will ensue, and this will ultimately result in cardiac arrest if we're unable to stabilize the myocardium from the overwhelming calcium channel blocker toxicity. So you want to consider securing the airway early in these patients and aggressively while they've still got some form of hemodynamic function, remembering that intubating these patients that are shocked can result in cardiovascular collapse, but these patients are going to get further refractory shock as the body metabolizes the calcium channel blocker. You want to get an ART-line and CVC in these patients early. Okay, ART-line, so you've got real-time end-of-the-bed blood pressure monitoring. Bill was given 3 litres of CSL and his blood pressure came up to 74/32. He was then given calcium. Remember, calcium is an antidote for calcium channel blockers, so giving him calcium. So he was given 60 mils of 10% glucose, and this temporarily increased his heart rate and his blood pressure. But we need to restore his hemodynamic function as well, and the calcium is not going to be enough. So we can try atropine. You can go up to about 3 milligrams, and that's most probably going to be your maximum dose there. We're going to need to give some form of vasopressor or catecholamine infusion to increase his contractility. So we can look at adrenaline, noradrenaline, dopamine for that. Well, there's a newer type of concept that we can do, which is high dose insulin therapy. Okay, so this is where we're giving high doses of insulin to actually overcome the calcium channel blocker toxicity. So it's referred to as HEAT, which is high dose insulin euglycemic therapy. And its mechanism is where HEAT allows the heart to overcome the metabolic starvation that results from calcium channel blocker toxicity. There are other poisonings where we can use HEAT, such as beta blocker toxicity. And it's to help with the compounds, the direct cardiotoxic effects. So we know that giving high dose of insulin and the insulin release from that is dependent on the calcium influx into the beta cells and the calcium channels within the heart. With calcium channel blocker toxicity, insulin induces an actual insulin resistance. So we know that these patients will often present hyperglycemic. And so the calcium channel blockers may also impair the cardiac myocytes. And this is where they get free fatty acids and they get this resting state energy substrate. and cardiacs. And so this is where they'll get the impaired uptake of glucose and free fatty acids by the cardiac myocytes. And there's a very complex pathophysiology process, but we know that insulin and giving high doses of insulin will actually overcome that and actually restore and improve their hemodynamics. So the thing is that you start off with is that you're going to give them a bolus of short-acting insulin. So this is Actrapid. So you'll give them 1 unit per kilo IV. So in an 80 kilo man, you're going to give him 80 units of IV insulin as a bolus, and this saturates those insulin receptors. We're also going to need to give glucose as well, because they can become hypoglycemic from it. And then you're going to run them on an insulin infusion. So you're going to run them at 0.5 units per kilo per hour. So we know that with Bill says 80 kilos, he's had the 80 units of IV Actrapid as a bolus. We're then going to run him on 40 units of insulin per hour to actually overcome. We're going to have to run a dextrose infusion as well, because they will get hypoglycemic, and we know that when they're actually getting more, when we notice that they're getting more hypoglycemic, that's when it's an indication to start titrating down the insulin infusion, and that you're actually overcoming that calcium channel blocker toxicity as well. So it can be a bit daunting for nursing staff to give such a large bolus dose of IV insulin to these patients, but it does work, and it is a treatment to use for calcium channel blocker and beta blocker toxicity. Other things that we consider if these patients start to fail the high-dose insulin euglycemic therapy is cardiac pacing. So you're going to do ventricular pacing, but you don't want to exceed 60 beats per minute because they won't tolerate that and they're at risk of further arrhythmias. We can also do cardiopulmonary bypass, so these patients go to intensive care and go into ECMO and rest the heart and lungs while the body metabolizes it. And another thing is a balloon pump, but they'll genuinely need to be admitted to coronary care for that as well. We want to decontaminate these patients, and this is where we may look at stuff like giving activated charcoal. So you give it within 1 hour of standard preparation and within 4 hours for the slow release preparation. We can do whole bowel irrigation. Remembering to do whole bowel irrigation is where you're going to need a cooperative, or the patient will need to be intubated, and we'll do this within 4 hours of deliberate self-poisoning. And we'll do that in these presentations because they do have such a high mortality even with a good standard of care. So whole bowel irrigation is where generally you put in a nasogastric tube, and we'll give them stuff like Go Lightly. Every hour you give them 1 to 2 sachets of that until they're actually passing clear stools out through their rectum, and that's to try and prevent the body from actually absorbing any more of the calcium channel blocker. These patients will generally get admitted to ICU or HDU because they're going to need ongoing monitoring for at least 24 hours. If you've got a low toxic dose of ingestion with calcium channel blockers, and this is for standard preparation, so if they've got normal vital signs at 4 hours and an ECG, they should be safe to discharge or to be seen by psych. With your slow release presentations though, they need to be monitored for about 16 hours, and if after 16 hours they've got a normal ECG, then they're safe for discharge as well. So your take-home points from your calcium channel blocker overdose is be prepared early for refractory hypertension in these patients. Insulin is the key to resuscitation. Give calcium because it's the calcium that's been blocked by the calcium channel blockers. Consider intubating early, and consider whole bowel irrigation in these patients. And finally, we're going to finish off with the last case. So this is a 54-year-old Tiffany. She presents feeling just out of it. She's felt on and off for the past 12 hours. She reports that she's got shakes and chills. She's got palpitations with a cough and shortness of breath, and she's very confused and restless. So she's got quite a lot of non-specific type symptoms there that need further investigating. So poor Tiffany, she's also got a background history of depression and hypertension, and she's seeing a GP currently for some thyroid issues. You notice that she's hypertensive, so a blood pressure of 184 on 106. She's got a heart rate of 130. She's got a respiratory rate of 22, It's at 95%, but she's also febrile at 38.7. She gets seen by an intern that orders some bloods and an ECG. Her urine comes back with a bit of lukes and nitrates. She gets charted some tazocin. She gets given some fluids at 250 mils an hour, and the intern's worried that she may have urosepsis. Then Tiffany's bloods return. We notice that she's got a HB of 118. She's got a mild raised white cell count at 13. Her lactate's 3.2, but she comes back with profoundly elevated thyroid levels. So thyroid stimulating hormones at 7, her T4 levels at 40, and her T3 levels at 800. So she's got severely elevated thyroid levels. And so this is consistent with thyroid toxicosis. And so thyroid toxicosis is basically where you get excess thyroid hormone in circulation, and it can be caused by overproduction, release from the injured gland, or from an exogenous hormone in the body as well. With thyroid storm, though, these patients present with severe left ventricular dysfunction from those high thyroid levels that has this direct effect on the myocardium. And we need to have a high index of suspicion. So patients that present with like endocrine signs and symptoms or a history of endocrine disorders, especially pertaining to the thyroid, think about, could this be thyroid storm? So when should you think about a thyroid storm? It is a clinical diagnosis that's based on the history, vitals, and examination. So if they've got underlying hypothyroidism, so that's most common we see in patients with Graves' disease, and occasionally in patients with toxic multi-goiter or toxic adenoma. They present with fever and thyroid storm because these patients have have lost that ability to vasodilate and thermoregulate, and so they can present quite hypothermic. They've got an altered mental state, which is the key to diagnosis. So this can also present as restlessness to delirium seizures or comas. And a suspected precipitating event. So the common cause include infection. Like we saw with Tiffany, she's got some abnormal urine there. So that could be a trigger for it. Trauma, surgery, or excessive diuresis is another cause when we should think about thyroid storm in these patients. So your signs and symptoms that we'll see with hypothyroidism is that they often will have big bulging eyes, dilated pupils. They can have facial thyroid flushing. You can actually genuinely palpate the thyroid in the neck. They'll present with cardiovascular signs of tachycardia and hypertension. They may report some weight loss, muscle wasting. You can see some localized edema, diarrhea, finger clubbing and stuff. So looking for those clinical signs and symptoms at the end of the bed. Your management, generally it's very supportive. So we're going to give IV fluids. They may need some glucose replacement. They will need some cooling, generally to maintain that because they can't ability to thermoregulate. So you may need to actively cool these patients. We may treat that fever with paracetamol, but it's best to avoid things like NSAIDs or aspirin because this can displace the thyroid from the proteins. We can also give propranolol or esmolol boluses, so this can help with some of those cardiovascular signs and helping support that left ventricular dysfunction that they're occurring. Specific treatments that we may give as well is hydrocortisone because they can have some adrenal insufficiency as well, and that decreases their T4 release and conversion to thyroid stimulating hormone. There's other things that drugs that we can use is prothyrouracil, which is given as a 1 gram load orally, and then 250 milligrams QID, and that inhibits the thyroid hormone release and decreases peripheral conversion from T4 to T3. But after we give the polythyrouracil, we also need to give sodium iodide, potassium iodide as well to actually help maintain that thyroid in a reasonable functioning state. So that's all I've got for you for this talk, and there's just a couple of things that I want to finish off, so a couple of pearls to finish. So if you're dealing with a refractory shock case, I think to remember that patients can often present with anaphylaxis, but they don't actually manifest those cutaneous symptoms in about 10 to 20% of patients. So they may not develop the urticaria rash, the lip swelling, the bronchoconstriction. They may just present with severe hypertension. So don't rely on those cutaneous type symptoms to make the diagnosis of anaphylaxis. And if you think it's much best to treat it and give the adults the 0.5 milligram of IM adrenaline and see what effect that has. So think about anaphylaxis as a last ditch in patients that are presenting shocked in front of you and you're having trouble to work out what's going on. And then this is a mnemonic that I've got from Cliff Reed as well for actually when you're looking at the end of the bed at the patient with hypertension and shock, what to actually do. So he uses the alpaca mnemonic. So the first thing is actual hypertension. So we want to actually check transducers, check other limbs, and making sure that we're getting accurate blood pressure measures. We want to check our lines. So we want to make sure that the vasopressors are going in and that they haven't extravasated or the fluids haven't extravasated. So if we're giving a treatment and it's not working, just make sure we're doing it right. Using POCUS, so POCUS is point of care ultrasound, and this actually can help us. So doing an echo to exclude pump failures and obstruction as well can give us a lot of information at the end of the bed about the patient's state. Think about adrenal efficiency as well and considering treating with hydrocortisone. Check the calcium always, so look at it on the blood gas, and if it's low and the patient's shocked, optimize the calcium by giving something. And in the patient that suddenly gets worse, as I just said on the previous slide, think about anaphylaxis. And is there an ongoing allergen exposure, or do we need to treat something that we're missing there? So think about the alpaca when you're looking at these patients at the end of the bed. So the take-home points for this talk is prepare and think about what you're going to do when you get to the end of our algorithm in these patients with shock. Calcium replacement is underrated. Remember, it's not always sepsis, so think about things like Addisonian, Brash syndrome, hypercalcemia, thyroid storm as well in the shock patients. And be very aware of calcium channel blockers and beta blockers, because even 2 to 3 times their normal dose can result in quite profoundly shock and hypertension. That's all.